I will talk about management of multiple sclerosis, and this is Rashid Hospital. I think most of you are familiar with it. MS is a chronic inflammatory autoimmune disease that affects the central nervous system. It's mainly due to demyelination in the white matter, as well as axonal degeneration and gliosis. And traditionally, it was thought that it is due to T cells that was affecting the CNS, but now, and in the past at least 10 years, the B cells have a big and a major role in multiple sclerosis. So the interest in MS is everywhere in the world, and here in the UAE and in Dubai, we also have a significant number of patients with MS. The prevalence of MS in Dubai is 54 per 100,000. And there was a publication in 2011 that looked at the prevalence and incidence of MS in Dubai. So what are the causes of MS? So till now, we are not sure what actually causes MS, but we know that it is an autoimmune disease. Is there a genetic element? It's a possibility. Is it an environmental reason for it? It's another possibility. Or is it a post-viral related autoimmune disease? Pathogenesis, I will not dig into because I know that time is running, but as I mentioned, it is due to the autoreactivity of the T cells that basically gets reactivated with a disrupted blood-brain barrier. And this T reactivated cell, cytokines, immunomodulator are released and triggers the B cell to pass the blood-brain barrier as well, and more inflammatory mechanism happens, leading to finally demyelination of the CNS. So I will just jump the pathogenesis. The symptoms and signs of MS is important for us to identify a patient. So visual symptoms, a common symptom that most multiple sclerosis patient will come with is acute diminution of vision. Double vision is another symptom. Sensory symptoms that are significant, so significant tingling and numbness that has been going on for a while. Weakness is also one symptom, and what's common more is monoparesis or monoplegia. Then comes paraparesis, then in frequency, basically, quadri, and finally hemi is a less rare presentation of MS. Bladder symptoms such as urinary precipitancy is also a common symptom, dizziness and vertigo, as well as incoordination, imbalance, and hand shaking and tremor. Also feeling that one's limb is stiff. That's another symptom that a patient would come with. Again, cognitive symptoms can happen. They usually come later in the disease, but they happen with MS. And then other symptoms that are not tangible, such as fatigue, exhaustion. These are symptoms that patient might have experienced for a while before reaching their diagnosis, or they accompany the MS symptoms, as well as other symptoms such as impotence. So the MS is divided into several phenotypes, and I think you're familiar with them. The relapsing remitting type, which is as an attack happens suddenly, acute onset, the patient reaches a maximum of a disability. Then this symptom starts to resolve, whether spontaneous or with treatment, and the patient might go back to the normal baseline. And then after few months or several years, another episode of another disability happened. And this phenotype, we call it relapsing remitting. The other phenotype is the secondary progressive, which is the progression from relapsing remitting to secondary progressive. So a disability happened, the patient goes back to the baseline, and another attack after, let's say, a year happens, and so forth. But with accumulation of disability, we start building up disability. And the patient goes from relapsing remitting to secondary progressive. So with the buildup of disability with time, so he never reaches back his baseline, the normal, and disability keep on creeping, and another attack happened. This is what we call secondary progressive MS. Then there is the primary progressive MS, where there is never a clear-cut attack. The patient cannot pinpoint an attack, but they feel that there is disability that has been insidiously encroaching on him. So for the past 5 years, he's been feeling that his left limb is weak, and it's becoming weaker and weaker, and now the right limb is also starting. This is how a primary progressive MS describes their symptoms. Then there is the progressive relapsing, which is the same as primary progressive with an event that happens acutely as well. So to diagnose patients with MS, we have a criteria, McDonald criteria. It has been updated for a while now. And the latest we have for relapsing remitting MS and another one for primary progressive. So to diagnose relapsing remitting MS, we need to prove there is dissemination in time and in place. In time, we need 2 attacks. So the patient has to describe that they had acute diminution of vision 2 years ago, and now they're coming with imbalance. These are 2 attacks, and dissemination in space. So when you examine the patient, you have 2 objective findings. So I examine the fundus and I see optic neuritis, and I examine for example, his limbs, and I see weakness. So I have to prove there is dissemination in time and in place. And then there is the investigation role. So the investigation role is basically to replace if there is a missing dissemination in time or space. So there is the MRI to prove the diagnosis if either of them is missing, or if there is CSF oligoclonal bands in it. Again, the practice is that we do the investigation either ways, whether we have the full criteria component there, we support it with our investigation. I will have to run, so I'm not going to go into details of each one. The primary progressive, we need to have 1 year of progressive disease. So the patient has to have at least symptoms for at least 1 year, and there has to be MRI criteria that is there, and CSF as well. So there are other patients that we never were able to prove they are MS because they did not fulfill the criteria of MRI or of the dissemination in time and space. So this is what we call clinically isolated syndrome. This is a patient that comes with, for example, a disability that is acute diminution of vision, but this is the first attack. So they don't fulfill the criteria of dissemination in time and space. And when we do the investigation, the MRI and the CSF, they also do not fulfill it. So in this case, we call this patient clinically isolated syndrome. And these patients are there so that we follow them up. There's also something called radiologically isolated syndrome. These are the patients that incidentally we saw demyelination on the MRI, whether it was because they had, for example, a car accident and MRI was done for them, and we saw demyelination. So how to treat MS? Typically, there are 2 schools to treat MS. One of them is to escalate the treatment, and one of them is to hit hard the disease earlier on. So this is a publication that came, and it was comparing those patients that were diagnosed with clinically isolated syndrome and received earlier disease-modifying therapy versus those that were postponed. And this publication shows that those that received earlier disease-modifying therapy, their conversion into MS was statistically significant to a delay of 3 years. This is also another publication that came that was showing us treatment of early relapsing MS and the conversion to become secondary progressive. And it shows that if you treat relapsing multiple sclerosis early with this disease-modifying therapy, you are delaying the time for the patient to change into secondary progressive. So while choosing treatment for the patient, it's basically upon the disease. We have to look at the patient profile. As an MS patient, what are the presentation, the disability, the significance of the disability, as well as the radiological finding, how active is the patient, and what do they prefer, because they are the ones that are getting treatment. So we have to consider patient specifics, which is the disease activity. Are they highly active patients? By highly active, we mean they have more than one clinical attack per year. And is the MRI highly active as well? By highly active, we mean that they have new lesions when we do the MRI for them, whether it is a T2 flare or a contrast-enhancing lesions. And by this, we can define highly active patients. So again, the strategy for multiple sclerosis is either you start with disease-modifying therapy that is safe, and the patient does not want to take highly efficacious drugs because of the profile of the side effects. So some patients will decide, no, I want to go with the safer drugs. The side effect profile is safe. I don't want to go with the highly efficacious drug. It suits some patients if the disease is not highly active. This is a suitable strategy. However, for those that are highly active, they are having significant disability, more than one attack per year, as well as a highly active MRI, it might not suit them. So therefore, we prefer in this case to advise the patients that we need to hit the disease hard and to start highly efficacious drugs. Again, the strategy for treating clinically isolated syndrome, this is not yet a confirmed, clinically confirmed MS, but all the disease-modifying therapy that are the first line are available for them, such as the interferon beta could be used for them, as well as the other first-line treatment in MS, which is the teriflunomide, as well as the dimethyl fumarate. Now, treating MS, relapsing remitting MS, we divide them, as I mentioned, into non-aggressive or not the highly active and the highly active. And we can offer the non-aggressive patients first the interferon beta treatment, which is subcutaneous injection, glatiramer acetate, which is subcutaneous injection as well, teriflunomide, as well as dimethyl. These are oral tablets. These are all suitable as a first line for those that are not highly active patient. Fingolimod also is a suitable as a first line. If these patients fail and there is not a good response, they are having more disability, we can then escalate the treatment as I mentioned before. But if the patient is a highly active, from the beginning, they come with a significant quadriplegia, hemiplegia, these are significant symptoms, and the MRI is highly active. You see contrasting lesions that are gadolinium enhancing, as well as none. You want to hit the disease hard with disease-modifying therapy, and in this case, we want to start early because we don't want to wait for the brain volume loss. So in this case, the recommendation that is there, and this comes from the Min-Ektram's recommendation, is to start with highly efficacious drugs, such as the immunotherapy that we have, as the monoclonal antibodies, the natalizumab, ocrelizumab, alemtuzumab, and all the monoclonal antibody therapy are the first line for those highly active patients. Now, what about the primary progressive patient? So we have primary progressive, and the only approved treatment for it is the ocrelizumab, which is a monoclonal antibody, anti-CD20. So I hope it is clear in one's mind the treatment for clinically isolated syndrome, as well as the relapsing remitting. We divided into highly active and active MS as well as the primary progressive.
2 minutes.
Can I have, yeah.
We'll give you 2 minutes, Doctor.
So this is just to show the safety and the main side effect of every disease modifying therapy that is available. And this is just to show that Rashid Hospital MS was the first approved as a Min Ekram's MS specialty center. Thank you very much for your time.